Hey everybody, I just want to go through this lecture on occupational lung disease. As an outline, we're going to talk about asbestos, silicosis, coal workers, pneumoconiosis, talcosis, tin, iron exposure, berilliosis, things farmers can get exposed to, and quickly about B reader status. So just it's part of definition. Pneumoconioses are the lung diseases related to inorganic dust inhalation, so silica, asbestos, coal, from the Greek konus. Um, we generally separate these from organic dust inhalation, which gives you more of a hypersensitivity pneumonitis pattern. Starting off with asbestos, two main types of asbestos fibers, the curly and the needle type. The curly type is what is currently used legally in the United States. It's banned actually in some European countries and Australia. But this type that we see normally, current day use in homes, uh, the U.S. feels that is not of any risk. We also have the needle type, which is the type that was outlawed in the 1980s, felt to be primarily related for asbestos related lung disease. So why to use asbestos? Well, it's very heat resistant, doesn't conduct electricity, so it's used a lot in home insulations, brake pads, ship insulation, those types of things. So in everyone's homes, there's going to be very high likelihood that you're going to have asbestos in your home, based on when your home, if it was built after the 1980s, it will be the serpentine type. Older homes could have the other type. Really, the only risk, on a daily basis is when those things get disturbed. So if it's in your insulation, your attic, the only time that it's really at any risk is during the removal or installation of that product. You can see here, this is asbestos sprayed on walls, or sometimes you'll see it in an old apartment building basement covering pipes. Is very commonly used in the interior of ships. I would say it's not an uncommon story for someone who worked in the Navy Yard in Norfolk to have asbestos exposure from years ago. This I thought looked very similar to this other picture here, but this is actually a picture of the hallway if you walk to the chest trailer. I called engineering. They told me it was sprayed concrete, but I still hold my breath when I go to work every day. They also, asbestos fibers also was used as fake snow in Hollywood. So this is actually asbestos fibers that they used to simulate snow. It's a fun fact. The exposure, most of the time exposure is really going to occur not in your home, but during mining, production, or industrial uses. Asbestos is a known carcinogen. So we'll talk more about it. We'll move into asbestos-related disease. We'll talk about asbestosis, which is very specific. We'll talk about round atelectasis, pleural disease, and neoplasms. So radiograph, at first glance, looks like you might think this is like a multifocal pneumonia, but when you start looking at the opacities, they're very well defined, almost geographic, and have pretty dense. And then you see these calcified pleural plaques here on the edge. These are actually plaques that you're looking through. You can see here on the CT. So these are those same plaques, just on the radiograph we're looking through them. So you get these kind of plate. Here's more plate-like, but here you're looking on, through the whole plaque. The couple test questions that can come up with these pleural plaques, they can ask you if it's on the parietal or visceral pleura. The plaques are on the parietal pleura. You can remember PPP, or somebody remember it. They do calcify. They tend to overlie the ribs. They're bilateral. So if you see unilateral calcified pleural plaques, I usually would not come to the conclusion that they've been exposed to asbestos. Usually I would think Blood in the pleural space from trauma or infection would be probably more common for unilateral pleural plaques. But bilateral calcified pleural plaques, I would say, consistent with prior asbestos exposure. You can have these parenchymal bands adjacent to the plaques and pleural fusions. This is a common kind of board style case where they'll show you a calcified pleural plaque and this swirling atelectasis or round atelectasis comet tail descriptor, volume loss. It's a generally you should walk away from this as rounded atelectasis. Don't recommend a PET CT. Don't recommend biopsy. And you can just walk away from this if it has this classic appearance with this comet tail kind of swirling sign and is commonly associated with calcified pleural plaque. Now, asbestosis is interstitial lung disease that is in people who also have been exposed to asbestos. So here you have, it's not that it looks totally different than other interstitial lung diseases. So typically, in a testing situation, you would see a calcified pleural plaque, or they'd show you a calcified pleural plaque as the hint, and then they'd show you this terrible looking lower lobe predominant lung disease with possible honeycombing. So asbestosis. Patients are dyspneic, can have digital clubbing, this kind, not that kind, and have progressive symptoms, despite if their exposure was years ago. On radiographs, the shaggy heart appearance has been described. Again, this is 20 and 30 years after the exposure. CT, pleural disease is common. So if you have asbestos, the interstitial lung disease, it's common to also have the pleural plaques. And again, it's more of a UIP type pattern where you have intraocular septal thickening, lower lobe predominant honeycombing. So just in summary, to kind of separate the two, so calcified pleural plaques consistent with prior asbestos exposure, that really doesn't get you anything. Patients normally aren't bothered by that. But if you have interstitial lung disease, the honeycombing and bad interstitial lung disease that's associated, that is tied to your asbestos exposure, that falls into a very medical legal type environment, because it's typical that someone's employer didn't provide them a mask, or whether it was in the Navy shipyard or a brake factory or something like that. So you want to be careful about the use of the word asbestosis if they just have pleural plaques. Don't use that term. Moving on to asbestos-related neoplasm. So asbestos is a known carcinogen. It puts you at increased risk for bronchogenic carcinoma, so normal non-small cell lung cancer, for example. Sometimes someone might ask a question that says, "What's the most common cancer in someone who's been exposed to asbestos?" And mesothelioma will be listed as choice C, but other bronchogenic carcinomas, small cell lung cancer, non-small cell lung cancer, are going to be more common actually than mesothelioma. Mesothelioma is associated, but it's still quite rare. And typically, the times that we suspect mesothelioma on CT is about the lobulated pleural thickening, not the calcified pleural plaques, but enhancing pleural thickening, especially when it involves the mediastinal pleura. And I'll show you an example of that in a second. Also, I've seen in a testing situation where it's asked if the plaques are a precursor lesion. They're not. So the calcified pleural plaques don't turn into mesothelioma. They just share. It's just a hint of a shared risk factor. We want to look closely for chest wall invasion, because that will limit patients to be able to have surgery, which is an extrapleural pneumonectomy, which is quite an extensive surgery. Radiograph with some irregular pleural thickening. Move on to CT. If I just showed you this part, you might say this is an empyema, but it's pretty irregular to see this kind of creep along the mediastinal pleura in that way. And typically you might be given a history of weight loss or something, or rather than infectious symptoms. But this was mesothelioma. Staging, which we don't have to go into, but it's there for reference. A couple test questions. So, what is the earliest identified thoracic abnormality associated with asbestos exposure? Plaques, fusions, asbestosis, which again is the interstitial lung disease, or mesothelioma. So the question again, earliest would be pleural fusions. Again, just watch the keywords for earliest. Great. Moving on to silicosis, rock mining. Again, both of these, both asbestos and silicosis, it's a prolonged, it's a long exposure, and then there's quite a long delay before the classic radiographic findings that will show. Central lobular nodules, upper lobe predominant. You can get collections of these nodules that kind of coalesce together. They can have some little calcified bits in them, and they can form these larger masses when they conglomerate, and that diagnosis is called progressive massive fibrosis. Also can have calcified hylar lymph nodes, sometimes in an eggshell pattern. Don't have a radiograph of this patient, but it's a CT scout. You see some upper lobe, something going on in the upper lobes, a fibrotic process pulling everything up. Then on CT, if you just had one side, you'd say, well, this is cancer, because it looks kind of scary like cancer. But when you see it on both sides, that would be rare. And then you kind of start to see how this chronic fibrotic process that's really pulling things up and distorts the airway. That's kind of your hint that this is something else. Also the high density, you can see the high density within the lesions in the masses, and then also lymph nodes should get you to the diagnosis of progressive massive fibrosis. Another, with silica, if you're sandblasting or rock blasting and aerosolizing in an acute setting, if you inhale that, you can get a more acute process. Again, the other progressive massive fibrosis is 10-20 years. This is kind of more an acute setting where you get this acute pneumonitis. Here in this example, this would be the crazy paving. This is what crazy paving is. Interlobular septal thickening with ground glass. And the most classic, usually when you talk about crazy paving, the first thing on your differential is going to be PAP, so pulmonary alveolar proteinosis, but just as an aside, but silica proteinosis, if you inhale silica dust acutely, can give you this crazy paving. These are diagnoses that you typically are given hints, not something that I include routinely in a differential if I'm not given those hints otherwise. Good. Moving on to cold-workers pneumoconioses. It's pretty indistinguishable from silica, but again, you typically are given that history, or at least hopefully at some point during the patient's care, you're given that history. Again, upper lobe, central lobular nodules, and progressive massive fibrosis. This is a case with central lobular nodules. When we talked about eggshell calcifications, that's what this is. So just the periphery is calcified. So certainly with this, these central lobular nodules and a history and eggshell calcifications, this is a good case for cold-workers pneumoconioses. Talcosis can also appear similar. You can either inhale talc if you're working in a talc factory or mining it. More recently, we've seen there's been cases published of talcosis so apparently if you crush up your OxyContin, you can heat it and inject it, and it has the talc, which is the filler material within the pill, and you can have this perihilar central lobular nodules. But recently they used to be able to grind up OxyContin like this and then inject it, but now they changed the formula so it all clumps up and turns into this gel, so you can't draw it up in a syringe. I thought that was kind of interesting. But I'm sure there are some pills that you can still crush up and inject, but just an aside, this was actually a real case of a patient who was injecting their pills through their Metaport. So you can see those central lobular nodules diffuse. Amazing. Tin or iron inhalation. Again, it's a metal dust that if you can, uh, it's called siderosis if it's iron, stannous if it's tin. Again, the patterns are not going to be all that different. You really are given this as history um, rather than putting on a differential of something that you just see. Berilliosis. I guess there's some ceramic industry that uses beryllium. The main point of showing this case is it's on the differential for sarcoidosis. So when you see upper lobe predominant fibrotic process, um, I've seen in a testing situation where it's even asked something along the lines of what disease or what inhalation can mimic sarcoidosis. It's beryllium inhalation. So, not something I come across in practice, uh, truth be told, but I have seen that in a testing situation. Which of the following matches or work related are lung disease are correct? Asbestosis and hyaluronitis, no. Berilliosis and upper limb reticular changes, that's that sarcoid-like, so I think that's the choice there. Co-workers and small lower lobe motion. Now the inhalation stuff is going to be more upper lobe, and silicosis and pleural effusion, no. So B, again, this sarcoid-like or similar appearance to sarcoid with beryllium. In addition to organic dusts and allergens that farmers can be exposed to, there was also some chemical exposures. So we'll talk quickly about those. Silo fillers disease is one where it's basically a nitrous oxide that is the bacteria produce in the silo. And then if farmers are in the silo or exposed to it, they can get an ARDS or acute pneumonitis from that. So that would be a pertinent history called silo fillers disease. Popcorn lung, we were talking about this the other day, not because we had a case, but it came up. It goes back to why does buttered movie popcorn that's microwave, it's actually tastes buttery, not because they put butter in it, it's because they put diacetyl in it, which is an artificial flavoring. It's chemical. The I remember in chemistry class we'd smell it and it smelled like butter popcorn. It's also what makes certain Chardonnays buttery. They don't put it in there, but it naturally occurs. Fun facts for your friends when you're at a winery that buttery Chardonnays are because the fermentation process is producing a diacetyl, not that there's butter in it. It can result in a bronchiolitis obliterans pattern, which is good to just talk about. So bronchial wall thickening, air trapping, ground glass is going to be the bronchiolitis obliterans pattern. This was a guy who, so there's been some exposures in workplaces with diacetyl and cases related to that. This was someone who actually just ate a lot of microwave butter popcorn. So true story. He ate 2 or 3 bags a day, which doesn't seem like that much, and developed bronchiolitis obliterans. And he sued Kroger. I guess he was eating the generic Kroger popcorn. Awarded $7.3 million. You can look it up. Wayne Watson. Amazing. And there's a ton of lawyers now. Popcornlung.com. Lots of settlements. Popcorn lung. So good. So we ran through asbestos and asbestos-related lung diseases, some silicosis and co-workers pneumoconiosis, some of the other rare things, but just some quick pointers to remember. Now, quickly, I'm just going to talk about B-reader status. B-reader status, I just want you to be generally aware of it. Basically, there are certain standards for reading radiographs for occupational lung disease. it's highly regulated, and they want you to report it in a consistent manner. There's a test. It's actually quite a hard test to pass, from what I've heard. Alan Roth is the only B reader um, in our group. He's actually the only radiologist that's a B reader in the state of Virginia. Um, he went and took this test, got certified, um, so he can. So he gets called on when this is needed at times. So if you're in a practice in a part of the country um, that has occupational exposure, um, you may want to get this B reader status. It might be something that would benefit you, distinguish yourself from your colleagues. Um, again, it's mandated by this Federal Mine and Safety Act. Um, the U.S. Department of Labor may ask you to read chest X-rays for patients exposed to asbestos. If you take the course, you're an A reader, but if you pass the test, you're a B reader. It's kind of weird. At the time I made this, there's only 300 in the United States. There's probably even less now. I won't go into any detail of this, but it's this wacky codes and size of opacities and nodules. This is a TT and a QQ. I mean, very strange stuff, but you have to memorize this stuff, take the test, and then if you're asked to read radiographs, you have to fill out this form and talk about distribution. I've never seen that, but just again, so you're aware, it's quite involved. But again, as you will go out into practice, things that you can kind of list on your skill set that your colleagues may not have are just going to benefit you in a workplace environment. So if you are certified to, you take the ACR course and certified to read CT colonographies, and no one in your group is certified or something like that, it helps you in the long run. So just be aware of these kind of smaller, less common things that may help you at some point. And that's pretty much it. I ran through it quickly. This is one last, I just wanted to kind of give you a quick overview of some occupational lung diseases, introduce you to some of the topics, and point out some things that might come up in a testing situation. This is one slide that I came across when preparing this in the agricultural disorders of the lung. I thought it was pretty interesting this is just talking about the hydrogen sulfide concentration, or how bad the manure pit smells. Initially at low doses, it's rotten eggs. And then as you go up, it gets to be unsafe. And actually the higher it gets, the worse it gets for you, is you lose smell. So you don't smell it anymore. And then you die. And I was just surprised by that. And then, so I kind of thought that it was a good analogy for work, that if you really hate your job working in the manure pit and can you no longer smell the bullshit, then death is imminent. Hope that helps. Thanks a lot.